aortic aneurysm, aortic trauma, or rupture. There is always a race against time for clinicians with a critical illness, and aortic dissection and syndromes uh, pose a great challenge to those clinicians, in that the classic presentation of acute aortic agony is categorized by severe sudden onset pain in the chest or back. This presentation, although recognizable, occurs only among minority of cases. Initial manifestation of acute aortic syndromes are highly variable, and establishing the diagnosis requires specific testing. Therefore, arriving at the appropriate diagnosis in a timely manner is probably often challenging. Owing to the early mortality risk, prompt recognition of acute aortic syndromes enables the early treatment and early decision making, which may potentially improve outcomes. Starting with the aortic dissection, we really need to know what is it, and how can it happen. Aortic dissection usually starts with an intimal tear, a tear in the intima of the aortic wall, which exposes the underlying media, which is usually weakened by medial degeneration. We'll talk about the etiologies of medial degeneration further in this discussion, which would expose this weakened media to the shear forces of blood flow, which would cause a longitudinal cleavage of the muscular media, literally tearing it apart. This cleavage front advances due to wall strain in the direction of blood flow, although dissection against blood flow have been observed. This accumulation of blood flow in the false lumen, which create a pressure differential, which could accumulate and increases pressure, which may compress the through lumen. This compression can be dynamic or static. The compression potentially can compromise the downstream blood flow of the through lumen of the aorta. Another complication, we can see an example here in example A. In example B, we see another complication of aortic dissections. The resulting intima flap may obstruct branch vessels, leading to end organ malperfusion, resulting unfortunately in stroke, limb ischemia, or visceral malperfusion. Classification, we have generally two classification systems recognizable. Those classification systems, although purely anatomical, carry prognostic and treatment importance. Those systems are DeBakey and Stanford. The Stanford classification is a bit more simple and made it easier for us. Any dissection that is isolated to the descending aorta is classified as type B dissection, and any dissection that involves the aortic dissection, whether it affects the descending as well, it's classified as Stanford A. In the DeBakey, it gets a bit more complicated. Type 3 is usually isolated descending aortic dissection, which is further subclassified into type 3A and B if it affects the abdominal aorta. Type B dissection is isolated ascending aortic dissection, and type 1, the DeBakey, is involving the ascending and descending aorta with or without arch dissection. Isolated arch dissections are non-classifiable in Stanford, and when you have if you have an isolated arch dissection, is usually termed non-A, non-B dissection. Surgery is usually indicated for dissections in the ascending aorta, although where medical management is frequently the treatment of choice for descending dissections without associated end organ malperfusion or impending rupture. The optimal treatment for isolated arch dissections are still debated. Just quick facts about epidemiology. The incidence of aortic dissection ranges from 3 to 16 cases per 100,000 per year. The highest incidence occurs in the 6th and 7th decades of life among patients with hypertension. In one community-based cohort study, nearly 50% of patients with dissection died even before hospitalization. The 30-day survival for those who are admitted and hospitalized was nearly 50%. So this is a disease with monstrous numbers of mortality. Etiology and pathophysiology. The cornerstone of pathophysiology of aortic dissection is medial degeneration. So if you have any process that causes damage to the aortic media tunica, leading to medial degeneration, increases the risk for aneurysm, or dissection. In the case of a typical aortic dissection, the precipitating event is thought to be a creation of a tear in the intimal layer, overlying the damaged area of the media. So if you have a patient with medial degeneration is just waiting for the intimal tear to dissect. Of course, as we said, the cornerstone is medial degeneration. The etiology of medial degeneration can be different in some patient subgroups. So we'll talk about it in patient subgroups. And the elderly, the presence of medial degeneration is correlated with the effects of aging, hypertension, and atherosclerotic disease. Hypertension is usually found among patients in the elderly with aortic dissection, which is in 70 to 80% of patients with aortic dissection. Underlying biological processes have also been considered as contributing to the etiology of dissection aorta, such as inflammation and oxidative stress. In the young, medial degeneration is still the culprit. Young patients are more likely to have hereditary connective tissue disorders that compromise the integrity of the extracellular matrix in the tunica media. Most notably, Marfan syndrome, Loeys-Dietz, Ehlers-Danlos, and so on. In the pregnant woman, her pregnancy is an independent factor for aortic dissection. It usually happens in the late stages of pregnancy, in the third trimester or early postpartum periods. This risk is high, particularly in women with predisposing factors like connective tissue diseases. May occur among women without those predisposing factors, possibly to the elevated expression of relaxin and inhibin associated with pregnancy. Relaxin and inhibin are hormonal modulators that modulate the cardiovascular histophysiology to better accommodate the higher needs of the hungry growing fetus. Iatrogenic aortic dissection usually happen in the context of aortic manipulation, whether it is being in cardiac catheterization, anti-aortic balloon pump placement, or cardiac surgery. Cardiac surgeries involving the aortic valve appears to have the greatest risk. It is associated with high mortality risk, with the highest rates for those that occur during the early post-operative stages, with 42%. The prescription for a successful diagnosis is usually just to have a high index of suspicion. So a focused history and examination should be performed to assess the pretest likelihood of aortic dissection. Some of the triggers that trigger the clinician to think of aortic syndromes are non-genetic connective tissue disease or familial conditions associated with aortic disease. Typical chest pain presentation of aortic agony, history of recent aortic manipulation, high-risk signs such as pulse deficit, blood pressure differential, focal neurological signs, and new murmur of acute aortic regurgitation. ECGs are usually done for any patient with chest pain coming into the ER. The ECG is often abnormal in those patients, but is usually non-specific. Although the presence of ST segment elevation in late AVR in patients with type A dissection has been shown to be of prognostic value. Chest X-rays are likewise generally performed and is abnormal for most cases. 80% of patients with aortic dissection have an abnormal chest X-ray. Some of the signs that you can see in chest X-rays are widening of the mediastinum, displacement of the aortic calcification, and abnormal contour of the aorta, although this chest X-ray is normal. D-dimer is where it gets interesting. D-dimer of more than they found that D-dimer of more than 500 nanogram per ml has been shown to be highly sensitive for acute dissections, with a high negative predictive value of 96%, but is relatively non-specific. Based on this high sensitivity and low specificity, D-dimer can be used as a potential screening tool to rule out acute aortic dissection, like it is the case with PE. So if you have a patient presenting with chest pain, aortic dissection is on the differential. You want to rule it out. A D-dimer can be very useful. But of course, if you want to diagnose aortic dissection, you really have to see it. Some of the imaging modalities you can use is transthoracic echo, transesophageal echo, computed tomographic angiography, or MRA. Uh, Transthoracic echo is readily available, non-invasive, and portable imaging modality. Sensitive for the ascending aortic dissections, particularly if it involves the aortic root or the aortic valve. Complications such as aortic regurg and pericardial effusion can be easily visualized with transthoracic echo. Sensitivity for type A dissections varies between 70 to 90%, and sensitivities for type B dissection is on the lower side, approximately 40%. Giving this suboptimal sensitivity, performing a thoracic echo should not delay a more sensitive imaging study. Here we can see an example of transthoracic echo in a patient with aortic dissection. Here we can see the intraventricular septum is a bit hypertrophied, probably due to long-standing hypertension. Here we can see a very ballooned aortic root, very dilated, with the presence of the intimal flap just dancing around, or what they call a dancing membrane on echocardiography. Also, you can very easily see the aortic valve here, and with the use of Doppler, you can easily assess its function. So in terms of, we said that it's not definitive. Thoracic echo is not definitive. But if you need a definitive study to rule in or rule out aortic dissection, you might need the assessment of CTA, MRA, or transesophageal echo, which have enabled the diagnosis of aortic or acute aortic syndromes with very high specificity and sensitivity. Transesophageal echo offers a clear view of most portions of the thoracic aorta and affords an excellent information regarding the aortic valve function. It also may be useful to guide the surgical interventions for type A dissections. It has a very high specificity and sensitivity. Perhaps the most important procedural drawback regarding transesophageal echo is the need for conscious sedation, which might not be the most optimal choice when you have an unstable patient. Again, here we have another media showing the transesophageal echo, the mid-esophageal long axis view. Again, we see aortic ballooning, aortic root ballooning, and the intimal flap dancing. Here we can assess the aortic valve, and another view of the aortic dissection here with an aortic valve very clearly seen. And of course, you can assess its function from this view, which is the short axis view. CTA allows for a full view. The entire aorta has a very high sensitivity and specificity. Visualization of the intimal flap is usually considered. We usually consider the transesophageal echo to be the gold standard to visualize the intimal flap. But CTA have proven to have a comparable results in visualization. Pericardial and pleural effusions are often easily visualized, but blood flow and tamponade physiology cannot be assessed directly with the CTA. Also, you can have a dynamic CTA, but usually not done to the very high extensive radiation dose and the need for high doses of contrast. Management. The primary goal of treatment for a patient with aortic dissection is to minimize the effects of the dissection while rapidly evaluating the necessity for urgent intervention if indicated. Of course, be mindful of your ABCs whenever you approach any patient. The clinical stability should first be assessed to evaluate for acute complications, such as tamponade or acute regurgitation. The medical management of the stable patient is really having three pillars. The pillars of management is management of pain, the decrease of blood pressure to a minimal acceptable levels, and the decrease of the force of the left ventricular contraction. Pain management is usually titrated aggressively for patients with dissection. The goal of pain treatment for patients is comfort and the decrease of the sympathetic tone associated with pain. IV narcotic analgesics are effective for the rapid reduction of symptoms of severe. Sorry, IV narcotic analgesics are effective for the rapid reduction of symptoms severity, and the oral forms with long-acting narcotics are not usually recommended for those kind of patients. Blood pressure and ventricular contraction can both be decreased with beta blockade. Non-cardioselective agents such as propranolol, labetalol, and esmolol have been used extensively in this context. The goal heart rate with this treatment is to have a heart rate of 60 and a goal systolic blood pressure of no higher than 120. Of course, we hear targets the systolic blood pressure because of the shearing force of the systematic arterial pressure. So if your patient, so if you start your patient on beta blockers, you reach a target heart rate, but still the patient's still hypertensive. Here you can use vasodilators such as IV nitroprusside or IV ACE inhibitors. However, vasodilator therapy should not be used without concomitant beta blockade, given the possibility of an increase in heart rate and contraction force, accompanying its potent vasodilatory effect. In the rare event that a beta blocker cannot be used due to a contraindication such as bronchospasm, the non-dihydropyridine calcium channel blockers are the second-line agents, veramipil and diltiazem, both of which have vasodilator and negative inotropic chronotropic effects. So they decrease the force of the contraction and they decrease the heart rate. One phenomenon to be cautious about is pseudo-hypertension, which may occur when dissection propagates into the limb in which blood pressure is being measured. In such cases, it is recommended that hypotension be verified by measurements of blood pressure in other limbs prior to discontinuation of beta blockers or calcium channel blockers. So always scrutinize your blood pressure measurements before you take any action. Here's an example of prescription and guidance to prescription of those medications. I see labetalol is being extensively used in our institution. We usually start with a 20 milligram IV administered over 20 minutes, followed by 40 to 80 milligram IV Q 10 minutes, with a maximum initial dose of 3 milligram, to be followed with an infusion of 2 mg per minute up to 10 mg per minute. Of course, if you reach the if you reach your heart rate targets, but the blood pressure is very high, you can start to use nitroprusside as a vasodilator. Intervention. Optimal choice of therapy has not changed for nearly 30 years. A location of the dissection determines whether the patient should undergo immediate surgery. Acute dissection in the context of pregnancy require additional consideration and multidisciplinary evaluation. Type A dissection are treated virtually in all cases with surgery. Outcomes associated with surgical repair are superior to the outcomes with medical management. Nearly 25% versus nearly 70 to 50% 30-day mortality. So a huge reduction. The one potential contraindication to urgent surgical repair for type A dissection is concomitant stroke. Secondary to you fear the complication of hemorrhagic transformation of that stroke due to the extensive heparinization during OR. There is an evolving role of endovascular repair of type A dissections. However, surgical management remains the current standard. What they usually do is replace the affected ascending aorta with a graft, like we see here in this example. So when you push for surgery, one thing you should really consider is would your patient survive this surgery? Survival of patients with acute type A dissection who are treated with surgical repair has significantly improved over the last 25 years. In the past, patients who are older than 80 years were thought to have an operative risk too high to justify attempted repair, although this has improved over the last 25 years. A multi-center study reported an acceptable outcomes for aortic dissection repair performed in selected octogenarians. Of course, still it remains controversial, and each patient must be approached individually. Type B dissections generally managed conservatively. Urgent intervention is warranted in the setting of complications, including visceral or limb malperfusion, aortic expansion or bending rupture, progression of the dissection, or refractory pain or hypertension. Some further reading for those who are interested. The International Registry of Acute Aortic Dissection (IRADS) is a registry of about 470 something patients. They describe the natural history of their disease, how do they present, manage their management, and how did they fare. This has been my brief introduction into aortic dissection. Thank you very much.